Worldwide inaugural webinar sponsored by NTOD. Thank you, NTOD, for your support for this special day. International Women's Day 2022 campaign theme is Break the Bias. So imagine a gender equal world, a world free of bias, stereotypes, and discrimination, a world that is diverse, equitable, and inclusive. In a world where difference is valued and celebrated, and together we can forge women's equality. So collectively, we all would like to ask you to pose and break the bias. So I'm Famita Karani. I'm an oculoplastic surgeon in Vancouver, Canada, and I'm so excited to welcome you all today to today's webinar to celebrate women's achievement, raise awareness, and of course, learn about how to look a little bit more beautiful, which we all love to do. So I'll challenge you all to take a pose today in whatever you're doing and pose like this lady to break the bias and post it for and tag WOW, Women Ophthalmologists Worldwide. Wow. Thank you. I'm going to pause and pass on to Mohita. Dr. Sharma.
Thank you so much, Dr. Femida, and welcome everybody to this webinar of Women Ophthalmologists Worldwide, as well as Women Ophthalmologists Society. And it's a new initiative where this is an EyeSkin e-CONCLAVE where ophthalmologists are there with dermatologists, a very unique and new initiative. And it's a wonderful way to celebrate the Women's Day today by doing this webinar, because as ophthalmologists, there is a certain way in which we have been looking at our patients till now, and we want you to change your perspective with which you see your patients. So as of now, we have been seeing them as patients with eye diseases, but now we have to also start seeing them as humans who want to not just see good, but also to look good. So it's very nice to have dermatologists also with us, because they have a different perspective with which they see patients. And if ophthalmologists and dermatologists, they come together, then we can do wonders for our patients. So welcome everybody. And we have a very interesting faculty with us, very interesting topics. And we'll, before we start, we would like to invite Mr. Nikhil Masurkar, who's the Executive Director of NTOD. Thank you, NTOD, for making this event happen today. And we would like you to say a few words, Mr. Nikhil.
Yeah, wish you all a very good evening. Firstly, I would like to thank Dr. Famita Karani, President of Women Ophthalmologists Worldwide, and Dr. Mohita Sharma, General Secretary of Women Ophthalmologists Society, for putting this fantastic e-conclave together in such a short period of time, and that too on the occasion of International Women's Day. Now, I realize people may have different perceptions of what International Women's Day means, but for me, it's a day for the men to truly acknowledge a woman's worth and treat them as equal partners in every walk of life. It's a day to root out not just gender inequality, but also human inequality. We can only achieve genuine mutual respect for each other when we consider each other truly equal in every aspect. If you think high or low of someone, we can't quite seem to get that balance. So for me, this day is about seeing everyone equal and the same. We're all in this together as one. Very honestly, if it wasn't for my wife, I wouldn't be the man I am today. I wouldn't have achieved whatever I have today, and I wouldn't have felt the comfort, happiness, warmth, balance that life offers without her. And if there is any one day that I can genuinely express this with all my heart and with the utmost of honesty, it's probably today. Anyways, coming back to the webinar, my company, NTOD Pharmaceuticals, is one of the few who are specialists in eye, skin, and aesthetic medicine worldwide. So it's always been my mission to bring both ophthalmologists and dermatologists together on one platform so that they can exchange their ideas collaboratively on areas of common interest, such as ocular aesthetics, oculoplasty, reconstructive surgery, and under-eye skin health. There are so many overlapping medical conditions between the skin and eye, and having a joint discussion like this will allow a much more diverse perspective of the underlying pathology and its management. And which better way to inaugurate this EyeSkin e-CONCLAVE online series than to start it on International Women's Day with some of the world's leading women ophthalmologists and dermatologists all under one roof. I'm sure that this will pave the way for a new era of multi-speciality medical practice that can link ophthalmology, dermatology, and aesthetics in a way that hasn't been done before. So with the blessings of the Almighty and the elders in my family, let the action begin. Thank you.
Thank you so much, Mr. Nikhil. So thank you. And now we get started with our talks. And the first talk is by me. I'm Dr. Mohita Sharma, and I'll talk about getting started in aesthetics practice. So before I start, I want to tell you all that I'm not an oculoplasty surgeon, but aesthetics was something which I got started with around 4 years back, and I want to share my journey into facial aesthetics. And even before I start, I want to acknowledge Dr. Shubhra Goyal, because she was the one who, she in fact traveled all the way to Noida, and she introduced us to the concept of facial aesthetics, and it was a whole day spent with her, which motivated us to get started into facial aesthetics. I've been practicing basically for the last 22 years, and my specialty is cataract and refractive surgery, and I'm trained in retina, so I do some bit of medical retina also. So when I got started into facial aesthetics, a lot of my ophthalmology colleagues asked me as to why I was doing so. So this was the big question: why facial aesthetics? So this is my answer. These are my two answers to this. First of all, I always feel routine is boring. If we keep doing the same thing again and again and again every day, we tend to get bored, and we want to always learn something new, do something new to keep that to keep us stimulated and active. And secondly, I found that as surgeons, especially practicing surgeons, whenever you see a group of ophthalmologists standing together, the most common thing that they are discussing is how many cataract surgeries did you do last month, and how many did you do the month before that? And majority of the times their answer is, oh, it is not the same as what it was last year. This year seems to be low. Probably there is more competition. Probably there are more ophthalmologists coming up. So I thought, why are we all fighting over or competing over cataract surgeries? Let's do something new and something which is there right in front of us, but somehow we are not taking it up. And that is something which motivated me into facial aesthetics. I also read this editorial by Dr. Santosh Runawar in IGO, which said, let's face it, the potential of periocular aesthetics. And the figures that were there in that editorial were actually very, very surprising, and something that I didn't know about. According to the annual Global Aesthetic Survey 2016, there was a 9% growth in surgical and non-surgical cosmetic procedures. India ranks 7th in aesthetic procedures. And if you look at blepharoplasty, that's the world's most common cosmetic procedure. If you look at botulinum injections, these are the most popular non-surgical procedure. And together, if you combine the surgical as well as non-surgical periocular procedures, the numbers are estimated to be the same as 20 million cataract surgeries which are done in the world. So aesthetics, surgical as well as non-surgical, is same as cataract surgery. So why not get into this field? And especially because all those patients that come to you are actually asking for this, but this is a question which we have been often ignoring. I know that, and I'm sure many ophthalmologists will agree that a lot of our patients come and ask us, doctor, what should I do about my dark circles? What should I do about my wrinkles? What should I do about my baggy eyes? And most of the times we are not able to give them any clear-cut answer. We tend to, in fact, avoid those questions. We sometimes tell them, go do some steam inhalation. Or sometimes our answer is, this is genetic, or something like this is age related, but we never give them a solution. And we are only looking at their eye disease and treating their eye disease. Anything related to around the eye, we are just ignoring. So and surprisingly, plastic surgeons are the ones who are performing majority of the injection, majority of these treatment. So this is what got me into the world of facial aesthetics. And after the first priming that was done by Dr. Shubhra, then we took a training course in which there was a pre-training and learning about botulinum as well as fillers. And Dr. Shilpa was my colleague there. So, and we went back into learning. And that was the first time, in fact, I realized that a face can be divided into 3 parts, and what facial aesthetics mean and what aging of the face means. So it was all very interesting, and we all got started into this. We learned, finally we got certified also, and then we came back and made changes in our clinic. We had some aesthetics written somewhere. We tried to change the way our clinics look. These standees started appearing in our clinics. So all this got started. And there was extensive counseling and some marketing activities also happening to get hold of aesthetics patient, because we had learned a skill. But I would confess that despite learning all this, nothing was working out till this patient came. And this, as they say, patients pays and patients pay for aesthetics too. So this was around an 80-year-old man who came for cataract surgery, and he suddenly asked me, doctor, can you do something about my wrinkles? And I was like jumping, because this was my first patient. So I did a treatment with Botox for him, and this on the right side you can see the effect, and the patient was actually jumping when, apart from cataract surgery, he got this too. So this is what motivated me, and this patient taught me one very important thing. He taught me that we don't have to do any marketing, we don't have to do any extensive counseling. These patients are there within our clinics. There are patients who are there with dark circles. There are patients who are there with eye bags. Within our patients who are coming for eye diseases, somebody coming for LASIK, somebody coming for cataract, those are the patients who also have these problems. And those are the patients who want to get treated. Just sharing some examples. For example, this patient came for cataract surgery. I also suggested to her, why not go in for treatment of your wrinkles on the forehead? And this patient immediately agreed. In fact, when we gave her a option of cataract surgery with multifocal lens and with botulinum, this patient wanted cataract surgery with monofocal lens and botulinum. She wanted to save the money on the lens, and she wanted to spend it for looking better. So that's the kind of motivation which some patients have. So our slogan became "See good and look good." And now in our routine cataract surgery patients, LASIK patients, we advise them these procedures, and we find that they take them up very well. Not all, just a few as of now, but yes, whoever takes them up, they are happy. And hence, this is how this journey of aesthetics started. And now recently I came across this product, and so this seems to have become an answer for dark circles. In fact, I myself have dark circles, so I was the first. I became my own first patient. I've started using them, and I hope I can already see the difference. And I hope just as we saw in the video, my eyes also become same as the change that was seen in that video that we just saw before this presentation. So the change that happened with the aesthetics was that learned an interesting new skills, had happier patients, and this was a new revenue model. And of course, there were new oculoplasty friends also. And after that, of course, we thought that trainings is the need of our, why not teach it to others also? And we started these training courses also, which we were running. And because of COVID, we gave a short break, and now we'll be starting them again. So the message that I want to give to the ophthalmologists is that join the new world of facial aesthetics, and your patients need more than what you have been doing till now. And simple things like dark circles, eye bags, etc. If you treat, you will find that your patients are happier. So I end by saying I shall be telling this with a sigh. Somewhere ages and ages hence, two roads diverged in a wood, and I took the one which was less traveled by, and that's what made all the difference. Thank you. So with this, I would next invite the next speaker, and the next speaker is Dr. Nidhi Pandey. Dr. Nidhi Pandey is the head of oculoplasty services at Indira Gandhi Eye Hospital at Lucknow, and she would be talking about anatomy and aging, a very, very important topic as far as aesthetics is concerned.
Good evening, everyone. A very happy Women's Day to everyone. I'll be talking about periocular anatomy. Let me just, yeah. So as we all know that eyes are the window to the soul, but given its beautiful, vivid expressions, the upper face unfortunately bears the brunt of the earliest signs of aging. So having a sound knowledge of anatomy is imperative, not just to avoid the danger zones while doing non-surgical and surgical anti-aging procedures, but also, I don't know why my animation is not working.
Just move your cursor on the slide and then proceed further.
Yeah. So as I was saying that a sound knowledge of anatomy is imperative to prevent us from the catastrophic consequences of going into some certain danger zones of the face, but also in fine-tuning our results to reverse the clock of aging and give excellent results. Coming to the first sign of aging, which are the dynamic lines or the rhytids. So we all know that most of the fine lines and the wrinkles start around the eyes. And why is that so? So these are the muscles which are responsible as we age for the different kinds of lines we get around the eyes. So the main elevator of the eyebrows and the forehead is this vertically oriented paired muscle called frontalis, which arises in the galea aponeurotica and merges in the supraorbital rim. It interdigitates with the orbicularis oculi fibers. Now, rest of all these muscles are the depressors, starting with the corrugator supercilii. The procerus, which is again a vertically oriented muscle, starts from the fascia on the nasal bone and extends upwards and interdigitates with the frontalis muscles between the two bellies. The depressor superciliar and these orbicularis oculi muscles, which have three components, the orbital, the preseptal, and the tarsal, and it surrounds the eye 360 degrees. So now, one thing that we have to understand is that the fine lines develop perpendicular to the action of the muscle. So now that the frontalis is a vertically oriented muscles, so the lines would be the horizontal forehead lines that we see. And these have to be removed by injecting neurotoxins into the frontalis muscles. Similarly, procerus, being a vertically oriented muscle, leads to these horizontal lines on the bridge of the nose, often known as the bunny lines. Now, corrugators, being laterally oriented, leads to these vertical frown lines. And the crow's feet are again perpendicular to the fibers of the orbicularis, which are horizontal, while the fibers run vertically. Again, we have to keep in mind two anatomical distances which help us in fine-tuning our results. One is the 1 to 2 centimeters, staying 1 to 2 centimeter away from the lateral canthus and staying at least 2 finger widths away from the eyebrows to prevent the eyebrow droop. Also, we have to consider that while injecting the orbicularis oculi, there is this muscle called levator palpebrae superioris, which is the elevator of the eyelid. So we have to prevent injecting the pre-septal orbicularis to prevent ptosis. Also, we have to identify and keep in mind the zygomatic arc and try stay above it to prevent the droop of the angle of the mouth. Certain finer details of the shape of the brows and the iris is that the brow is arched and the apex of the brow is somewhere lateral to the lateral limbus. The upper eyelid apex is slightly nasal to the center of the pupil, and the lower eyelid apex, or the nadir of the lower eyelid, is just lateral to the center of the pupil. The lateral canthus is slightly above, almost 2 millimeters above the medial canthus. Now we see this crease, which is almost 7 to 8 millimeters in males and 10 to 12 millimeters in females, and this is due to the attachment of the levator aponeurosis. The extent of the eyebrows, the medial end can be roughly determined by an imaginary line perpendicular to the base of the alley of the nose, and the lateral end of the eyebrows can be roughly imagined extending from the oblique line passing from the ala, crossing the lateral canthus. The horizontal ends of these of the eyebrow are almost at the same level. There is a subtle difference between the male and female eyebrows. Usually the male eyebrows stay at or below the superior orbital rim, while the female eyebrows are more arched and remain above the superior orbital rim. So while injecting the neurotoxins, we have to be careful in female eyebrows not to flatten the eyebrows and lead to a brow droop, and in males not to inject too laterally in the depressors, leading to what is called a Spock brow. Coming to the static lines, which are the sags and the bags, which come later during the aging process. So two important anatomical landmarks which we can easily keep in mind by just palpating the orbital rim is the inferior orbital foramen, which is 8 to 10 millimeter inferior to the inferior orbital rim. We can just palpate around the eye and keep these landmarks in mind. The superior orbital notch can be palpated as a notch while we are palpating the superior orbital rim. And these are the locations of the inferior and the superior vessels and nerves respectively. So there's an extensive vasculature supplied by the branches of ophthalmic artery and facial artery, especially the medial aspect. We have to be careful about the angular vessels, which are almost 6 to 8 millimeters medial to the medial canthus. Any emboli anywhere in the face can lead to end organ infarction. Coming to the aesthetic surgeries and the anatomical considerations we have to keep in mind. So the muscles of the face are interestingly connected with each other by virtue of these things called fascia, the superficial musculo-aponeurotic system, or the SMAS, which continues above into the galea aponeurosis as temporoparietal fascia above the zygomatic arc and continues into the galea superiorly and into the platysma inferiorly. Now this is a loose tissue, but it has connections with the periosteum through these retaining ligaments. And hence, the retaining ligaments being the areas of valleys where the SMAS is attached to the periosteum by virtue of these retaining ligaments, which extend from the periosteum, cross the SMAS and attach to the skin, while the rest of the portion by virtue of the process of aging sags down, leading to the hills. An important surface anatomy is marking the course of the frontal branch of the facial nerve, which starts 0.5 centimeter in front of the tragus, crosses the zygomatic arc in the middle 1/3 where it is most superficial, and ends 1.5 centimeters lateral to the tail end of the eyebrows. So it's better to mark it while we are doing brow lifts or surgeries around this area. Another is this conjoint tendon, which is the fusion of all the fascia to the periosteum. So to continue to make this layer continuous with to make the forehead continuous with the temporal area, you have to lift this up. Also, as I've already mentioned, the supraorbital notch. So marking these ahead of our procedures saves us from going into the danger zones. Coming to the fat pads. So the preaponeurotic fat pad of the upper lid has a central portion and a nasal portion. We have to be wary of the lacrimal gland, which might look similar to the fat pad in terms of its pale yellow color. So we have to keep this in mind and avoid damaging it. We have to avoid damaging the superior oblique tendon, which can lead to squint if it's damaged. Also, subtle addition to our surgery would be conservative excision of the nasal fat pad, as they're considered to have more adult stem cells. Inferior, there are 3 fat pad components divided by the inferior oblique and its arcuate extension. Certain clinical pearls which we can add during our procedures. Now as we know that our face has these fat pads, so we have to keep in mind that below the orbicularis oculi in the lower lid is the suborbicularis oculi fat pad, which is continuous superiorly and laterally to the retroorbicularis oculi fat pad. Now these retroorbicularis oculi fat pad gives the temporal fullness and youthful appearance of the lid. Also, while aging, what happens is that the orbitomalar ligament stretches and descends, pulling the soothe downwards. And in addition to this, because of the laxity and thinness of the tissue, the inferior orbital rim appears very prominent, leads to the skeletonization, and the malar fat pad prolapses due to the stretching and thinness of the fascia above it. This leads to the double convexity. So attaching the soothe with the OML gives a mid-face lift just by a transconjunctival approach. Now, as I've already mentioned, the importance of retroorbicularis oculi fat, it may be bulky in some patients and some patients may require excision of it, but we have to be conservative because it gives the fullness and the temporal lift of the eyebrows. One of the dreaded complications of the lower eyelid blepharoplasty is the lower lid retraction. There are certain things we have to keep in mind when considering the anatomy of the lower lid is identifying the anterior lamellae, which is the skin and the orbicularis, the posterior lamellae, which is the tarsus and the conjunctiva superiorly, and the inferior retractors and the conjunctiva inferiorly. Very important is identifying this fusion point, which is the fusion of the orbital septum with the inferior lid retractors. While placing our incision, if we place our incision below the fusion point, we can directly enter the fat pad, and this area is approximately 4 to 5 millimeters below the inferior border of tarsus. Avoiding extensive excision of the skin and orbicularis, preserving the pretarsal orbicularis oculi muscle, and trying to attach the tarsus and or the orbicularis muscle with the lateral orbital rim prevents lid retraction. Thank you so much for your valuable time.
Thank you so much. That was
a lot of anatomy.
Yeah, good details, but we got to know some very, very important points. And thank you so much, Dr. Nidhi. So we move on to the next talk, and that is by Dr. Manjot Gautam. Dr. Manjot is the professor of dermatology at Dr. D.Y. Patil Medical College, Navi Mumbai, and she's also a consultant dermatologist at Apollo Hospital, Navi Mumbai. So she will be talking about another very important topic, periorbital melanosis. Dr. Manjut, please.
Yeah. Thank you, Dr. Mohita. I'll just share my screen first. So good evening, everybody. At the outset, I would like to wish all the lovely ladies who are present today a happy International Women's Day. And I would also like to thank the WOW and the WOS for having me here. Also thank Entod for inviting me. So today my topic is periorbital melanosis. Now I am more into clinical dermatology and less of, I practice less of aesthetic medicine. But nevertheless, this is one condition where all the dermatologists, we have to manage this condition in our day-to-day clinical practice. So periocular pigmentation is also called as the dark circles or the infraorbital darkening. Here the patients generally present as bilateral, homogeneous brown or dark brown pigmented macules around the periocular region, that is the upper eyelids, the lower eyelids may be involved. Now, because of this gives a tired, sad, aged, and addicted look to the patients who have it. And therefore, it is a major beauty concern for men and women alike. In fact, it can affect one's self-esteem and also affect the quality of life of these patients. So, coming to the etiology of periorbital melanosis, with the etiology, it is multifactorial. Genetic factors are very important. Many a times the patients do give you a family history of similar dark circles. Lifestyle factors again are important. Stress, lack of sleep, alcohol overuse, smoking, diabetes can all result in the development of puffiness around the eyes, and which can impart a dark color to the periorbital area. Then extension of pigmentary demarcation lines. I would be showing you pictures when I explain this. Then certain skin conditions like melasma. Melasma generally affects the cheeks as well as the face, but extension of melasma around the eyes can result in dark circles. Then patients with atopic dermatitis can develop eczematous rashes around the eyes, which can again cause hyperpigmentation. Patients with contact dermatitis. In India, bindi dermatitis is very common. The kumkum generally may fall even onto the eyelids, resulting in eczema, which can heal with post-inflammatory hyperpigmentation. Acanthosis nigricans is commonly seen around the neck, but when the patient has severe acanthosis nigricans, which is a marker of hyperinsulinemia, even the periorbital area is involved. And sometimes, especially in the fair skin patients, they may have thin eyelid skin and a superficial location of the vasculature. Now, because due to the thin skin, the vessels, the capillaries and below the skin they can give a pink hue or maybe a blue hue to the eyelids. Now, photoaging, because of photoaging, the skin becomes wrinkled, you develop fine lines, the skin becomes more lax, the tear tuft becomes depressed, and all this imparts, a dark shadow effect on the lower eyelids, which is called as a shadow effect. Also, we shouldn't forget that certain chronic illnesses, including the connective tissue diseases, then patients having anemia, nutritional deficiencies, we often see patients with vitamin D and vitamin B12 deficiency presenting to us with, periorbital melanosis. Hormonal disturbances, including thyroid disorders, can all be the causative factors for periorbital melanosis. So this can be classified based on, if there is predominantly a pigmentary component. So where melanin is the chief culprit, so this will impart a brown color to the eyelid skin. Okay, if there is a predominantly vascular component, it will impart blue, pink, or purple color to the eyelid skin. Now, structural component, as I mentioned, because of laxity and tear tuft depression, causes dark shadows on the lower eyelids. But majority of the patients have a combination of these factors. So this is what I was talking about, the pigmentary demarcation line. Now, this is a sharp or an abrupt, demarcation between the normal skin as well as the hyperpigmented skin. So what you can see is a sharp demarcation here. Here, the pigmentation is homogeneously brown. So this is the classical, V-shaped pigmentation. Now it can extend over to eyelids and result in periorbital melanosis. Now this is very commonly seen in the dark skin population. If you have a tendency to develop this, then hormonal changes during pregnancy can bring about the manifestation. Similarly, patients who are more exposed to sunlight are more prone to develop PDLs. Okay, but why I brought out PDLs is basically because it is a normal condition. It cannot be treated very easily. The condition is very persistent. It doesn't respond to depigmenting agents. So counseling plays a very important role. Here, you have to stress on the patients that they have to avoid direct sunlight, use sunscreens, and although depigmenting agents may have some effect, but nevertheless, they may have to use cosmetic camouflage like concealers. As against the PDLs, here you can see that there is mottled pigmentation. The pigmentation is not uniform. It is very prominent on the malar areas of the face. You can see the pigmentation on the nose. In this picture, you can see the bilateral pigmentation on the malar areas affecting even the face. This is a patient of melasma, which can again extend here. You can see over the lower eyelids to give rise to periorbital melanosis. Now, as I said, majority of the patients have combination of features. Now, this patient has melasma on the face, but at the same time, you can see here that he also has a tear trough depression, as well as he has thickening of the skin because of acanthosis nigricans. Another patient, you can very clearly make out that she has an eczematous rash on both the upper eyelids, which you can even appreciate the periorbital melanosis. Now, this atopic dermatitis generally heals with post-inflammatory hypopigmentation. And what are the features that can help you? The dermatitis, as well as she may have similar lesions elsewhere on the body. So another patient with acanthosis nigricans. Now, how do you differentiate? In acanthosis nigricans, it is not the melanin which is deposited into the skin, but it is basically the skin becomes thick. So you can make out here that the skin is, overlying skin here has become hyperkeratotic. It is better to feel, and because of this thickening of the skin, it imparts a pigmented look to the periorbital areas. Now, this is basically a sign of insulin resistance. And once you're diagnosing acanthosis nigricans around the eyes, most of these times, even in this patient, if you see her neck, there is pigmentation around the neck also. Another patient with acanthosis nigricans, besides, she also has xanthelasma palpebrum. Now, this patient, you can see the classical tear trough depression, which is imparting a shadowing effect on her lower eyelids. The vascular component, now this was a fair skin patient who has a thin skin, which is giving a pink hue to her periorbital region. So how do you approach a patient with periorbital melanosis? Well, a detailed clinical history and examination is very, very important. You need to identify the primary cause, and then you can have an individualized approach for treatment of these patients. So as I mentioned earlier, a family history is very, very important. History of drug intake, especially estrogens, the long-term use of hydroquinone, even the use of ocular hypotensive drugs like bimatoprost, latanoprost can cause periorbital pigmentation. So if there is history of these drugs, then you need to stop the offending drug. Then, as I mentioned, atopic dermatitis, allergic contact dermatitis, you need to treat them with either topical corticosteroids or with topical calcineurin inhibitors like tacrolimus or pimecrolimus. Then people who are who have a history of chronic sun exposure, which can cause development of fine lines, wrinkles, laxity of the skin. So you have to stress that they need to maintain strict photoprotection. They have to use sunscreens as well as the sunglasses. Yeah, do not forget to rule out systemic conditions. So most of my patients who have periorbital melanosis, I generally tend to ask if there is history of chronic illness, maybe 3 to 4 months before they develop dark circles, then whether they have underlying, anemia. So a CBC is very, very important. I always do a vitamin D level, B12, as well as TSH for these patients while treating them. So clinical examination should be done in a well illuminated room, preferably under natural light. Now, there is a test to differentiate the different components. So the true pigment can be differentiated from the shadow effect versus the vascular component. So if you manually stretch the lower eyelid skin, now if it is true pigmentation, which is because of melanin, obviously because of stretching of the skin, this color is not going to fade. So the pigmentation remains as it is. Whereas if it is because of the shadow effect, so it was just the dark shadow because of the depressed eyes. So when you stretch the skin, this tends to improve or resolves completely as the light reflects well on the lower eyelids due to stretching. And if it is the vascular component, or it is because of the thin skin, when you're stretching the skin, you're further making the skin thin, and because of which the pigmentation accentuates, and thereby the underlying vascularity becomes more obvious. So these are the tests we can do. So we generally do a Woods lamp examination, which helps us to differentiate between epidermal and dermal pigmentation. Now, under the Woods lamp, if it is purely epidermal pigmentation, the pigmentation accentuates, whereas if it is a dermal pigmentation, it remains the same. Again, dermoscopy, which is a handheld scope, helps to differentiate between pigmentary versus the vascular component. We often use it in our OPD. USG may be done to differentiate the vascular cause from the periorbital puffiness. Usually, we do not do a skin biopsy because of the aesthetic concerns, but in case if there are other inflammatory conditions like lichen planus, which we need to differentiate, then we may go for a skin biopsy. So coming to the treatment, well, the aim of our treatment is to identify and treat the primary cause of hyperpigmentation, as well as to treat the contributing factors. I mentioned earlier that it is very important to use broad spectrum sunscreen with an SPF of minimum 30, and you should use UV coated sunglasses, which are beneficial in the treatment of periorbital melanosis. For PDL, which are persistent, you can offer your patients cosmetic camouflage, including the concealers. Treat the underlying nutritional deficiencies. I often add oral antioxidants containing beta carotene and vitamin C for my patients. Now, coming to the topical skin lightening creams, well, they are basically targeted in reducing the melanin content of the epidermis, and there are numerous agents that are available in the market. The most potent of them being hydroquinone, 2 to 6%, but hydroquinone generally is, we generally use it on the face skin. Skin around the eyes is very delicate and sensitive. So we have to be careful when we are prescribing a hydroquinone based cream around the eyes, because one of the side effects being irritation. Okay, again, one of the side effects with hydroquinone is exogenous ochronosis, and therefore we should not be using it beyond 12 weeks. Then other agents like kojic acid, azelaic acid, tretinoin, they are all agents which can be used. Yes, azelaic acid, generally I prefer to use it for periorbital hyperpigmentation due to post-inflammatory hyperpigmentation. Also, it works well in acanthosis nigricans, where it helps to reduce the thickness of the skin. And at the same time, azelaic acid is safe on prolonged use. Tretinoin again can be used as a short contact therapy for acanthosis nigricans, but it is an exfoliating cream and it can cause severe irritation around the eyes. So if you're using tretinoin, you should limit the use to maybe just 15 minutes to 30 minutes and not go beyond that. These are other agents like arbutin, vitamin C, vitamin K. Yeah, vitamin K and caffeine gel generally target the vascular component. All other agents were targeting the pigmentary component, whereas vitamin K and caffeine generally target the vascular component. So if the patient has a vascular component, these agents will definitely be useful. Now, one thing I would want to say is that since most of these agents that we use around the periorbital skin are mild depigmenting agents. Therefore, most of the under eye gels or the serums that are available in the market they generally add a combination of these agents so that you can have a synergistic effect. So this was my patient whom I treated with, sunscreens, moisturizers, and topical cream, which contained retinol and vitamin K. And you can see that this was the post-treatment photo, which was taken 3 months after she had presented to me. Chemical peels we often do in our patients with periorbital melanosis who don't respond to topical agents alone. So generally we use milder agents because again the skin is delicate. So if I use maybe a 30-40% glycolic acid on the face, I would just limit the use to 20% glycolic acid around the skin around the eyes. Okay. Yeah, so this was one of the photographs of Dr. Dayal, which I took from the internet. Yeah, so this was a patient where they did glycolic acid peels 20% and got good results with it. So lasers can also be done, but in the Indian skin, generally we don't prefer doing lasers because of the dark skin. So lasers are ablative and they can, the healing can occur again with post-inflammatory hyperpigmentation. So yeah, so whatever data, majority of the data that is available is from the Western literature, but we do have different lasers which can target both the pigment as well as the vascularity. For example, the Q-switch 2B laser will target both dermal and epidermal pigmentation. The Q-switch Nd:YAG laser targets both pigment and vascularity. The pulse dye laser targets mainly the vascular component. Sometimes we may have to use the ablative lasers, especially for treating the fine lines and wrinkles, and also for the treatment of acanthosis nigricans. So if the patient has a thin lower eyelid skin, then autologous fat transplantation would be the preferred treatment for periorbital pigmentation. And soft tissue fillers, including the hyaluronic acid gel, is useful for periorbital reshaping. It immediately improves the tear trough depression. So this was a photo which my friend Dr. Neetu Rajdev's patient, she shared this with me. You can see that before the treatment, the patient has dark circles and they have prominent, this patient has prominent tear trough depression. And immediately post-procedure, you can see that the shadow effect is gone and the periorbital hypermelanosis has improved. We can also do procedures like platelet-rich plasma, where we inject PRP into the tear trough area and into the wrinkles of the crow's feet for periocular, rejuvenation. Now, blepharoplasty is the treatment for periorbital melanosis due to shadow effect caused by fat deposits on excess of skin. So therapeutic, what should be the therapeutic approach? So if it is a pigmented variant, then sunscreens, the topical skin lightening agents are very useful. You can also use chemical peels as adjuvants, and in resistant cases, you may offer lasers. Whereas for vascular type of periorbital hypermelanosis, you can select the creams which contain vitamin K, the caffeine gel. And in resistant cases, again, you can use the pulse dye laser. For structural type, it is mainly the procedures like the soft tissue fillers or the autologous fat transfer which will work. So finally, I would like to conclude by saying that periorbital hypermelanosis is a commonly encountered aesthetically displeasing condition. The treatment is challenging. Often you may see subjective improvement, but it may be difficult to document it objectively with the help of photographs. This is less responsive to standard therapies because of the multifactorial etiology. Topical therapies and procedural therapies can improve the PUH and thereby improving the quality of life of the patient. Thank you.
Thank you, Dr. Manchot. Your talk was really refreshing and actually it taught us a lot. We as an ophthalmologist are often daily, I think 4 out of 10 patients complain about periorbital hyperpigmentation to us. And really 3 out of those 4 patients, we don't have any structural answer. So I was at least enlightened by the talk, and especially the PDLs, as you said, it is really challenging.
Yeah.
And the patients need a lot of counseling.
Yes. Thank you, Dr. Shilpa.
Thank you for enlightening us.
Yeah. I think Dr. Femida, would you want to comment here? I know you have been doing a course which talks about all the periorbital lotions and potions. Yeah.
You're muted, ma'am.
Thank you so much. Yes, we have a lotions and potions course that we've been doing for decades now at the American Academy, and you gave a great review of all the structural ways to look at periocular hyperpigmentation. So thank you for that structure. And also the options for treatment. And just like all of you have said, all patients, once they see better, all they notice are their wrinkles. Right? That was actually, many of us have been on the same journey. Once we fix their cataract, they say, now all I see are my bags. So it's our chance to help them see better, look better, and feel better. So I think it's wonderful. Excellent review. Thank you.
Thank you, Dr. Femida.
So I'll be having the next talk. I'm Dr. Shilpa Taneja, and I'll be talking about the most interesting topic of neuromodulators. Since the journey of aesthetics has started, I think the injection Botox or botulinum toxin is the one which has been in vogue always. And as we see the graphs, the minimally invasive procedures are always on the grow and with increasing trends. So this increased demand and need for such procedures has obviously led us to learn and have more experience in the field. We as oculoplastic surgeons, others more inclined towards learning it. Botulinum toxin, as we all know, has a heavy and light chain, and it cleaves the snare proteins, and thus the neuromuscular junction cannot function the way it wants to. And out of all the 8 antigenically distinguishable exotoxins, type A is the most potent and thus most commonly used commercial preparation we have. The type A toxin has 3 variants, ONA, ABO, and INCO, and all 3 are available in the market, and all 3 are US FDA approved. The Botox, ONA, Dysport, the ABO botulinum, and Xeomin, the INCO botulinum toxin, by Allergan, Epson, and Merz respectively, and thus all these 3 hold the market usually. Type B, Myoblock, also has been used in migraines especially, and there are many others like Botogeny, which many of my friends also use and are happy because of less financial constraints to the patients. But why are we discussing this? What's in a name? Because all of these have different chemical properties and biological activities, and for our safe clinical practice and to achieve optimal results, we need to understand the clinical issues of each one of them and thus stick to one, or maybe have practice in all of them and see your results and then inject into the patient. I don't have any financial interest towards Allergan, but all my results are with Botox Cosmetic. And as we all know, apart from patients having peripheral motor neuron diseases, neuromuscular junction disorders, pregnancy, any active infection, all the patients above 30 years of age, if have signs and symptoms, are bothered about small lines on their faces, are usually patients for injection botulinum toxin. And if someone asks me what is my ideal patient for Botox, a patient who's self-motivated, we are able to counsel and is ready to look good at a certain cost, but still understands the limitations of the procedures and doesn't have BDD, the body dysmorphic disorder, doesn't think that this is right and now this is wrong, is my ideal patient for Botox. And initially in the practice, always we need to be very careful why we select the patient. I usually reconstitute with 2.5 ml of non-preserved normal saline into the 100 units of Botox vial, and with 1.25 and 50 units vial. I will always tell everyone to have pre-injection procedures in which we must always document well and talk to patient properly. Later, patients might say we got pregnant because of Botox, leave apart the small other things. And the general principles of injection, cryotherapy, before you inject, always ask the patient to animate, assess, then inject, avoid thin blood vessels so that there are no contusions. Call back for assessment after 2 weeks when the patient Botox has taken effect. For aftercare, ask the patient not to lie down for 4 hours, not to rub or massage, not do any rigorous exercise, and use don't use any blood modifying agents for a week, especially green tea. Patients who want to look good, want to stay thin also are into taking ginkgo biloba and green tea a lot. Coming to medical indications, as in we learn it this ways: in upper and mid face, the forehead lines, crow's feet, glabular frown lines, Bully lines. For chemical brow lift and lower lid injections for thick roll under the lower lid are few of the indications in upper and mid face. Always assess the patient and ask the patient what they want. As in this lady, when we look at this lady, there is not much. And when we ask her, what do you want? She shows this. So she's bothered because of this thing, and she needs treatment for these lines and the lines on the nose, the nasalis area. This lady is more bothered about the crow's feet, especially not much about the forehead. Again, this lady bothered about the crow's feet. Thus, customize your patient. Customize the patient and the dose which you want to give at a specific area. See these two patients. These patients will have different crow feet injection, and this lady will have maybe 2 injections on each side. So far, as Dr. Nidhi has very well explained to us, the horizontal forehead lines, we inject after asking the patient to animate. Ask the patient to animate and inject a finger breadth above, not to cause brow ptosis. Use a 30 gauge needle. I'm using a 26 gauge here, very thick to penetrate the thick skin, especially in male patients. For glabular lines, which are the 11s in the center, hold the muscle, the procerus muscle, and inject into the belly of the muscle. The corrugators again has 2 sets, deep and superficial. Inject deep and superficial separately, 2 international units of Botox each. All these brow depressors, if injected well, give a good look post-injection. For crow's feet, either the injection can be in 3 sets either side or 2 sets on either side, depending upon the need again. So inject 2 units botulinum toxin at each side. Be very careful of the zygomaticus muscle, otherwise the angle of the mouth might droop. The nasalis muscle has to be injected for bunny lines. Coming to the indications of lower face, the perioral area here, which has wrinkles in the old age, the marionette lines, for masseter hypertrophy in few patients, and for platysmal bands. Perioral areas are easy to inject, but we should be very careful of the droop of mouth, and patients might experience chewing difficulty if the wrong muscle is injected. Dimpled chin, another, is a good indication, can be injected easily, either as a single point injection or as a double point injection. Just be very careful of the mental nerve. I have not personally injected platysmal bands ever, but it has been documented and has been shown to have good results. Thus, Dr. Nidhi also emphasized, and similarly, inject as the anatomy dictates. Once you start, you will know where to inject, how much to inject, when to inject, and what to counsel the patient. Just beware, don't completely paralyze the only elevator of the forehead, which is the frontalis muscle. Beware of the brow ptosis. The ptosis we might inadvertently create. Upper lip asymmetry, lower eyelid ectropion if injected more dose in the lower lid, and the spock eyes here. For spock eyes, we can again inject botulinum at the highest point to correct the deformity. Chipmunk faces, again, after multiple sittings, few patients develop this because the natural elevation of cheek goes down, and thus patient has the chipmunk cheeks, the unnatural resting face. These are few patients with before and after results. These results are after combination treatments, because usually patients, when they come, they have Botox and then fillers or threads if they want to. All are happy. Look at this lady. The periorbital hyperpigmentation looks very less. And this is just after injecting the Botox and fillers. Again, these patients, they look satisfied and are happy. They come to you again and again once they have experienced the effect of botulinum toxin and they want to get it again. So if used judiciously with proper techniques, Botox is really a wonder tool. And we must incorporate it in our aesthetic practice. Thank you all of you for your patient listening. Does anyone have any question?
It's a great review, Dr. Shelpa. I have used the platysmal bands and injected, and I find it to be very useful, especially because you can also do a Nefertiti lift and lift up the jawline. So it makes the jawline a little bit more prominent in certain face shapes. But excellent review. Thank you very much.
Thank you. I would now request Dr. Kasturi Bhattacharjee, who's heading the orbit oculoplasty, not only orbit oculoplasty, the cataract refractive surgery departments at Sri Shankardev Netralaya, and is a diva in her own respect. Over to you, Dr. Kasturi.
Thank you, Dr. Shilpa. Am I audible?
Yes, ma'am.
Yeah. So I have a huge topic. Basically, it's on evolving aesthetic application of dermal fillers. So I am a consultant to AMI, and let me start. Like, we all know that facial aging is often associated with the loss of soft tissue fullness in certain areas of the face, and many times it is associated with hypertrophy of the fat in other areas of the face. So injection dermal fillers basically balances this deflation and this deterioration. That is the hypertrophy and the hypertrophy. When we talk about dermal fillers, we know it got first approved by FDA since 1981. We have two types, irreversible and the reversible. Most important, they are being subdivided into synthetic and the natural. The synthetic, basically the PMMA, the hydroxyapatite, the polylactate, and the natural is basically what most of us use, the hyaluronic acid and the collagen. Different ways of injection, it can be in the form of threading, depot, fanning, cross-hatching, and also the bolus, which many of you do. But whenever we talk about the dermal fillers or any aesthetic procedure, we need to assess the face and also treat accordingly as in the pattern of the aesthetic hierarchy that we follow, where H1 is a full face analysis. We usually check the emotional attributes, whether the patient is happy, sad, saggy. H2, when we see the symmetry, as Dr. Shilpa has already shown the symmetry, we usually divide the face into 3 parts and see the proportion, the symmetry. 3 is basically the periorbital and the perioral region. We analyze both in static and in animated view. H4, the hierarchy 4 is very important. This is what the patient needs. So you might have to titrate or customize your injection as per the requirement of the patient. But H4, 5 is which is a big distractor for all of us, and we want to avoid it. This is especially in those patients who really wants like especially the body dysmorphic type of patient. So all these aesthetic, issues, they basically comes because of the visible changes which we get in the skin and the hidden changes that we get in the mass and the bone, which has been described very nicely by Professor Mauricio, where he has mentioned that there are 16 surface age triggering points and there are 8 bone triggering points. But the most important, what happens beyond this leads to ultimately the development of a negative vector from a positive vector. So what is this positive vector? If we see that in positive vector, the malar eminence is much anterior to the corneal plane, but as we age, because of deflation, deterioration, the hypo and the hypertrophy of the different parts of the face, it leads to a negative vector where you see the malar eminence comes much below the corneal plane. So what happens because of this, we get all the changes, but in the concept of treatment, especially when we do a filler procedure, we should all remember this line of ligament, which starts from your mesenteric to the masseter to the zygomatic and the temporal. So anything which is done lateral to this line of ligament is basically the foundation, that is for the lifting. Anything which is done medially is because of the volumization and also for the interior, for the redefining. So this is even when a patient comes to you, many times when we ask them what you want, they'll just lift a face. As you can see here, they'll just lift a face and they say that I want something like this. And this is the philosophy that we follow, especially when we use it, the different types of dermal filler. And the easiest for any of the beginners that they want to do is they need to do a hierarchy 1, the H1 and the H2 assessment, and start with the mid-face filler, which is very easy, followed by the chin and the jawline, because these are all the safe zone, where classically we say that basically CK1, CK2, CK3, where CK1 is basically the highest point of the zygoma, the CK2 is in the zygomatic prominence, CK3 in the malar region. But the advantage of this CK1 point that it gives a good lifting effect, it slims the face, it opens the eyes, treats the tear trough, treats the nasolabial fold, so it has got multiple advantages. But this is the same point which the plastic surgeons also believe, which they call as a G point. That is, if I draw a line from the tragus to the L of the nose and another line from the lateral canthus to the lateral part of the lip and bisect it, and the point which it meets borderline is known as a G point, which is the same point like the CK1 and the most important point for the lifting. So when as I have already mentioned, for the beginners, the mid face is the easiest, is the safest, where we have the classical CK1, CK2, CK3, CK4, but CK5 you usually give only in AIDS or who has a lipodystrophy. And you get the beautiful changes, as you can see this lady on her first visit and on the third visit. And this is how the changes occurs. And second visit is much better. And in the third visit with little additional touch-up, you can see there's much more ovalization of face. Mid face looks better. She looks much slim, the eyes appears wider, and in case with the CK point you see the nasolabial fold is not corrected, we can go for direct injection to the nasolabial line, that is the NL1, NL2, NL3, where you really get the wow effect, as you can see here, that is immediate effect in both the male and the female patient. This is how we go for the CK1, CK2, that is you go for a bolus. CK1 nowadays we go, that is the most important. In fact, the CK3 point is not much used nowadays, because when we go for the 7-point lift or the 9-point lift for the males and the 7-point lift for the females, we only go for the CK1 point, where we give 3 points for the CK1. This CK4 point is very important. This is a pre-auricular point, and this really gives a beautiful lift. And if you have only one syringe, and if the patient says that I can afford only one syringe, which point will you touch? You should always touch the CK4 point. Then the jawline is basically the JW1, which is basically you inject in the gonal point, and the chin, this is the C2 point, where you give a protrusion to the chin. Most important, the C1 point, which is the sublabial, the depression that you need to feel. But this point should be always done with the cannula, because it's a wide zone, the vascularity is high. It's not a very safe zone. So this is a point which I usually use the cannula, and with the same cannula, you can also give some supplement in the CK2. These are the CK4 and CK6 points, the 5 point, especially for the males. So 6 points where you make the jawline, which Femida has beautifully mentioned. We want to give a Nefertiti lift. And with this Nefertiti lift, we not only use Botox, but sometimes we also use filler to give a very beautiful jawline. So this is how you can see the jaw getting changed, and many times you want a very pointed or very sharp jawline, very beautiful change. This is how you do. But for ophthalmologists, the most important for us are the hierarchy 3, that is the periorbital and also the perioral region. So when we talk, the Dr. Gautam has already mentioned about the tear trough defect. But what is this tear trough? It is an oblique fissure, that is a concavity like deformity, and that usually occurs because of the separation between the palpebral and the orbital part of the extraorbital muscle. And this is the beautiful orbitomalar ligament, which has been mentioned by Shilpa and also by Nidhi. You can see that this is the osteocutaneous ligament which arises. This is from one of my patients that you can see here. So beautifully, this ligament has come out from the bone to the skin, and this all leads to the changes in the tear trough region. So we should know what is a correct tear trough and what is the incorrect tear trough. Correct tear trough, as I have already mentioned, it is a separation from the palpebralis part of the orbicularis muscle from the orbital part. And the indirect is basically the separation of the orbital from the quadricuspid muscle, especially the levator elegans side. So all this change along with the different periorbital hollows, as has been reported and published by Dr. Goldberg, what it leads to different types of periorbital changes, especially it can be in the form of a hill, it can be a form of a valley, it can be a combination of hill or valley, it can be a hill valley, or a mixed type when you have the festune. Or the better way is what we all follow, the PANG classification on the basis of atrophy, on the basis of the eye bag, and on the basis of the laxity, and this is how we titrate. So there are 6-step evaluation for the periorbital region. We need to say in the tilt, as we look down, we know we are much ahead, and when we look up, it is where we are in the younger look. We need to see the snap regarding the laxity, the smile. If there is a little bit of filler, and when the patient smiles, that means it's an improperly given filler, and this needs to be highlighted. Squinting, it always gives us a prominence, which helps us decide whether we should go for abscission before giving the filler. And this is when you have the prominent epithelial hole. And also in case of push, it is in a condition where we decide that the filler will not work. It is better you should go for the surgery, blepharoplasty. So as Dr. Gautam has already mentioned, the prominent tear trough are best treated with a filler because it takes care of the shadowing effect. Basically, the shadowing effect is gone, the tear trough is being corrected, and also gives a beautiful correction. But the question is, what do you do when there is an eyelid bag, whether you need to fill with the dermal fillers or you need to go for the surgery and go for the excision. So when you have the lower lid fat bag, which is much posterior to the anterior ligament crest, these are the situation where we go for injection dermal filler. But when you have this bag, which are quite prominent and much interior to the plane of the anterior ligament crest, these are the patient which we go for the lower lid blepharoplasty. So what I want to show you that this, you should know that which are the patient you need to go for the filler. If you have something very small like this, there's some amount of fat and some amount of tear trough, it is a dermal filler which not only conceals the fat, but also it corrects the tear trough, and it's a very beautiful correction, as you can see this patient. And also not only this, it also converts the negative vector to the positive vector. As you can see here, this is a negative vector before the procedure, and this is a positive vector after the procedure. So filler really gives a very good, and it is a wow effect. You can see I'm using a cannula just immediately following the procedure. You can see the bags and the trough that are being gone, and it really gives a very good satisfaction to the patient. Two ways of doing is first with the needle technique. I know many of you still prefer needle, and still, yes, needle is a good technique. When the patient keeps on repeatedly coming to you and you start with a cannula and later the patient develops too much of adhesion, then cannula may not be a good option. But a virgin patient is always best with the cannula technique. And then you need to inject it. First, the CK1 point, which I have already mentioned, because it lifts the tear trough, and then you inject along the orbital region, periorbital region. And the beauty is that, like this patient, you see this at this site has been injected, this is not injected. And you see at the completion, see immediately the bag has gone, the tear trough is much being corrected. This is what you see immediately after the operation. This is the injected site, this is a non-injected site, and then you go to the non-injected site and you complete the procedure. But what I have realized that in virgin tear trough, the best way is to manage with the cannula. So this is how you can see I'm being managing with the cannula, where you draw the infraorbital line, and then you need to inject along the infraorbital region. And this is what we have mentioned, the mini droplet bolus, that the mini bolus that we keep on giving along the inferior line, or you can also follow the traditional technique of TT1, TT2, TT3 points. And this are how you do on the first side, and the same procedure you do on the other side. And these are the changes you get. The changes are so evident. It is so beautiful. This lady just 2 days post-operative following the dermal filler. But the tear trough, I would like to mention that it appears easy, it appears beautiful. It can have lots of complications. So we usually say that the tear troughs are not as friendly as the dogs, but they can be tricky like the cats and can be dangerous like the lions. The other indication in the periorbital region, which nowadays I do lots of cases, like sometimes after injecting too much of Botox, what you see the hollowness, and you can see the loss of the volume in the periorbital region. So such situation, even in the crow's feet, if you give directly if you give the dermal filler, It gives a very good correction, very good rejuvenation. And this is what we also do in the periorbital region in many of the patients, where you inject the volumar just below. And here you should know the rule of the myomodulation. Another indication in the periorbital region is the eyebrow volumization, where you can use a cannula, you can use a needle, but this is especially a safer zone below the eyebrow, and this, the middle zone, is not a safe zone. So if it is below the eyebrow, you can directly go and inject in the periosteum, but usually the above part I use a cannula, but even if you use a needle, you should be very, very careful, and you need to aspirate before you inject. Try to be little lateral from the superior orbital foramina, because you know the major blood vessels are this, which gives a very good correction. The other hierarchy 3 is basically the lips. The lips can be managed directly with the injection that you can see with the needle. It gives a very beautiful correction, but still I also prefer, because sometimes what happens if you use the needle, you get the lumps and the bumps, which you will not get with the cannula. And now on my lips, I have converted by using the cannula, and I'm really happy because there'll be no bruise, there'll be no lumps and bumps. In fact, the whole face, I believe that it should be more done with the cannula than with the needle, because the chances of complications are much less with the cannula as compared to the needle. And you can do a very beautiful correction for the different types of lips, as you can see here, before and after the procedure, before and after the procedure, and after the same patient with some amount of lipstick. So as I have already mentioned, the lips are the best managed by the cannula. And you can see, especially in the northeast region, that is what you see. You can see there is good amount of volume here, the volume is less here, and it can be very adequately managed with the cannula, as you can see here. And next comes the hierarchy 4. The hierarchy 4 is what the patient wants. These are also very tricky situation. Like, she's such a beautiful lady, but what she wants a revision of the scar. So this can be done very well with the new Juvederm Volite. And this is how we manage the different types of scar. And also in this gentleman, the scar is really prominent. So you need to do an abscission. The abscission can be done. Usually if it's really the pinpricks or the big scar, if you see, you can use a 18 gauge cannula, or otherwise you can use a 22 gauge needle. And you do an abscission, and following the abscission, you fill up the area, especially with the Juvederm Volite, and you get a beautiful result. See, the scar is no longer there after at least 3 months following the procedure. So this is what the patient wants. It is a hierarchy 4. This lady who had a road traffic accident, and she wants a reconstruction of the nose, and you can see that the nose had been reconstructed so nicely, and she is now a much happy person as compared before. Even I say the post-blepharoplasty, when sometimes we end up excising all the fat, which nowadays I don't excise. I usually transpose the fat, because this fat later acts as a filler, will lead to a periorbital hollowing, which is iatrogenic. So what the patient wants is, she doesn't want a periorbital hollowing that you can see here. So these are the best patient where you can manage the periorbital hollowing. You mark the area to hollowing, and the best way is again the injection dermal filler into the periorbital region, and you will see beautiful results. As you can see here, I'm using the cannula, and you see the beautiful result just after the procedure. The periorbital hollowing is not there. The pigmentation, which is basically a shadowing effect, is being taken care of. So this is what the patient wants, and this is what falls in the hierarchy 4. Similarly, this patient after blepharoplasty, you can see there's so much of periorbital hollowing with the changes in the skin, and you can see that what I have done, I have again done the needle technique. I have done a periorbital filling up of the area with a needle, and you can see that she's much happy patient. Even when she animates, you can see here that you do not see all those lines, and also you don't see the hollowing. So before I conclude, like the effect, the results of dermal fillers looks wonderful, but fillers also have lots of complication. It is not a medication, it's a device. So since it is a device, there is no appropriate volume, how much to be given in which part. So many a times the volume may be too much, or it may be too little, it may be too superficial, or it may be too deep. And the superficial filler, which leads to nodules, as you can see here, which can lead to a Tyndall effect, as you can see this here, or also it can lead to lumps in the bumps, the nodules, as you can see here. There can be a hematoma, then can be excellent vascular complication, as you can see this, and also there can be another complication. All these are all resulting from the filler. But the advantage is that in the 5 we are also lucky to have the angiosomes. And when we talk of the angiosomes, we know that there are the choke vessels and the true anastomosis. So we are in fact lucky to have the choke vessels. And because of this, the chance of vascular complication is much less, though many of us are using fillers, but there are solutions to it. We should have the filler crash kit and also have all the necessary that is required to manage such situation. We need any complication, we need just to hilase it. But if there's a vascular complication, you need to flood it, which we call the hyle flooding, because the moment the hilase has been injected, there are lots of release of anti-hyaluronidase agents. So you really need to flood that area in case of vascular complication. Again, hyaluronidase has got lots of complication. As you can see, this lady, she was so happy with the filler that I have done that, but 6 weeks later, she comes with this nodule in the COVID era. I had given the Hylase, and you can see the angionotic edema on steroid, and it is much resolved. And with this, I conclude. Thank you very much for the patient hearing.
Thank you, Dr. Kasturi. That was really extensive. And yes, you had a big task at your hand and you did an awesome job with it. It was a real short crash course for all of us.
Sorry.
Thank you for all the, thank you for all the patients you have shared with us. And now I would love to invite a dynamic oculoplastic surgeon who has made ocular aesthetics, facial aesthetics her life and is touching new heights with her brainchild Clinica file. Dr. Shubhra, ma'am, please.
Thank you, Shilpa. And am I audible? Am I audible? Okay.
Yes.
Thank you, Shilpa, for that very warm welcome for me and Dr. Mohita, WOS. It's an honor, pleasure to be part of such an awesome, gathering of strong, wonderful, successful women. So after Dr. Kasturi's talk, as always, I have very less to talk because she's covered most of it and covered so beautifully. I'll be talking about eye bags, the surgical option. So, these are just for people who don't know, this is my pedigree of training where I have been. And I always say that I love being fit and beautiful no matter what age I am. I'm vegan and I love interior designing. So these are some of my interest areas beyond ophthalmology or oculoplasty. Before I start, I just want to dedicate this small video to all the wonderful women today as we are talking about the Women's Day. This was just a small thing. And as Famida had said, break the bias is the theme for this International Women's Day. So I just started this, just popped up in my mind that then you hated it and now you love it, where, we were talking about the features on the face we didn't love about ourselves some time ago and we've started loving them. So for me, it was my nose and my droopy or baggy eyelids. And what a coincidence that I get to talk about the eye bags or the baggy eyelids. So facial aging, as we all know, is all about conversion of a square, a V to a square or an inverted V phenomena. I'm not going to go into detail of it. The bags could be present at any age, in any gender, in any form, in any degree or severity. So there could be different forms of eye bags which we can encounter in our practice. But we have to be beware of what a bag and a fluid collection is. We have to differentiate between the two because fluid collection has a different pathophysiology and it's not treated the way the eye bags are treated. Now, apart from the aging, there are other things which we need to look into in terms of the internal health of a patient, which could have exacerbated the eye bags or would have caused eye bags, is if the patient has chronic sinus issues, has anything to do with, the tendency of water retention, which is hypertension, thyroid disorders, or any kidney disorders, we need to look into there's apart from that, the lifestyle which the patient is leading in terms of smoking, alcoholism, and etc. Because if these things are present, and no matter what you do for the patient may come back or may not have the best optimum results which you're trying to get with the patient. So what does actually the correction of eye bags do is it's correcting the firmness of the skin, correcting the contour of the midface, and we are working around these two by either augmentation, debulking, or redistribution, as Dr. Kasuri has said. And we are working on the contours and tendons which actually form the complex structure of the lower eyelids. Now, counseling, as Shilpa had mentioned and the other speakers have mentioned, is very, very important because most of these patients have very, very high expectation. We have to tell them, show them the asymmetry which is present on their faces, because for them, even the slightest asymmetry is a disaster. We have to have very clear communications. Please capture images, consultations which you are doing. We need to have a very friendly, good doctor relationship and not be in a hurry to treat these patients. And as always, please document and take the consent. Now, how do you actually decide, apart from what Dr. Kasturi had mentioned about the distribution of the fat related to the medial palpebral ligament and the crest? For me, also it depends on how much is the skin and how much is the fat. Is it only skin? Is it only fat? Is it the combination of both? And how do you deal with these issues in terms of whether you want to deflate it, reinflate it, or redistribute it? So my decision-making chart is very simple, based on the experience which I have gathered on my own. Is when you look at the fat pads, you need to look at the amount of fat which is protruding out and the amount of skin laxity which you have. So for example, this lady has grade 1 to grade 2 fat prolapse, which is more in the medial part, and she definitely has a skin laxity, versus the other lady who has the hill and valley effect, as Dr. Kasuri had covered, and not much of a skin laxity. Another patient who's a young patient, not much of skin laxity, but a more uniform amount of fat prolapse. More focused fat prolapse with again Hinner Valley effect, and somebody who has absolute grade 4 aging where everything is sagging and is loose. So these are the cases where you need to decide how to go about it. So I would just share my experience about how I manage these cases. So in this individual, my choice of treatment would be a blepharoplasty, where I would either excise or redistribute the fat and do the skin tightening. Now, skin tightening can be surgical or non-surgical depending upon what is to be done. Individuals where there is more diffuse fat prolapse with less amount of skin laxity or no skin laxity is where the fillers do wonders. More focal fat prolapse with hill and valley, they would do good with either surgery or fillers. We have to leave the choice to the patients. This lady opted for surgery, and this is immediately after the surgery, that is 1 week. Those scars are still evident. So these are some of the ways, my approach algorithm works. Now, there are two types of approach for eyelid bags for lower lid blepharoplasty, which is the anterior approach and the posterior approach. So there are certain advantages and disadvantages. The advantages of anterior approaches, it's an open sky technique. You can see what you're doing. You have a wider exposure to the field. You can work around it. It's pretty good to do in older patients where there is a lot of cheek ptosis, lid laxity. You want to work on multiple areas. But the disadvantage is, yes, it can leave a scar. You can have more complications as compared to the posterior approach, especially when you are a beginner. In posterior approach, yes, it is ideal for younger patients, very selected older patients where the skin laxity is not much, the fat is not much problematic. It does give a good access to the orbital fat. There are no scars, and reoperation, because redistribution of fat always happens. If that is there, then it's always easier to go from the posterior approach than anterior. But yes, it is not a good choice of treatment choice if somebody has a redundant skin or has a very hypertrophied orbicularis oculi. So another thing which I want to bring to the focus is that whenever we are doing these surgeries, it's always a good idea to assess the patient in the sitting position, in up gaze, straight gaze, and down gaze. We all know that the fat prominence will be more in up and straight than down gaze. So you know exactly where is the fat content, where is the fluid content, if the patient has fat and fluid. Mark your fat projections in a sitting position, because when you lie down or the patient lies down, everything falls backwards, and then there could be chances of under or over corrections. Now, I'm not going to go much in detail of the surgical steps because I know most of people here and in the audience know about it, but just a word on how the anterior approach is done. We take the skin incision along the subciliary line, go open the orbicularis, go deeper, open the septum, see where the fat prolapses. We press on the globe for making it more prominent and clamp it, cut it, and cauterize it. Versus in the posterior approach, it can be an open approach versus a small incision approach where we go just posterior to the tarsal border, open the septum, and then let the fat pad pooch out. Now, the word of caution here is never chase the fat pad, let it just pooch out on its own because that's a loose fat which is trying to come and trying to tell you that that needs to come out. Obviously, the junction between the medial and the central fat pad in the lower lips, inferior orbicular or inferior oblique muscle has to be kept in mind. This is the small incision approach, which is my favorite, where we just take around 2 millimeter incisions around the prominent fat pads, open the septa layer by layer, just let the fat prolapse out, and you just clamp, cut, and cauterize. So I always say not all smileys are needed, and this is a documentation of the fat and the muscle which you excise, and it's always a good idea to show your patients what you have done, where you have done, and how you have done. And these are some of the earlier cases which I had done where the patient just wanted to remove the fat and skin, and these are the results. Now, whether this is a good result or a bad result, I really don't know, because I think what it boils down to is the expectation of an individual rather than what we think as physicians or surgeons that this is not okay. Now, in my dictionary, yes, there is a hollowness which needs to be corrected. It would have been better if the patient had a redistribution of fat or secondary fillers, but if the patient is happy and satisfied, that's what matters. This is the same lady whom we operated with the posterior approach with the skin pitch technique. This is immediately after the procedure, and you get very good results in terms of the symmetry, the debulking, and the redistribution of the fat. Again, another individual where there were huge fat pads for the medial, central, and lateral pockets, and this is how we have removed it. This individual is extremely happy, and actually he became my spokesperson for a lot of other patients. Now, some of the patients would have the residual tear trough defects, which you can always correct with fillers at a later date. And never to chase the tear trough too medially, because that's your danger zone and you can stop there. And that's what the recommendation would be. This was my mother whom I operated. So she had grade 3 aging, she had festoon, she has fat back, she had lid laxity. We did an upper and lower blepharoplasty for her. This is her result, very natural. I would have loved to do a little more on her, but this is what she preferred to get as her results. Another case where there was very minimal fat, but more of a skin laxity, and we could manage to remove the laxity. Now she's on skincare to take care of a collagen thinning, which has happened all across the face. The post-op care is pretty simple as in any other cases. Now, some of the patients can have pretty heavy bruising and ecchymosis. Some of them may not have, but it's always a good idea to start your conventional treatment in terms of ice compresses, head elevation, limited activities, and copious lubricants, because post-blepharoplasty, like any other lid surgery, patients can have dry eyes, and it is very important to take care of that. Complications, like any other procedure, can happen. There can be infections, hematomas, asymmetry, lid contour issues, undercorrections, overcorrections, ectropion. Like this patient, was operated, and you can see there is a lateral ectropion. There is a disturbance of the lateral canthal angle. And if, of course, you're not careful with the handling of the fat pads or the kind of local anesthesia you have given, patient can even land up into blindness because of hematoma or a sudden bleed. In fact, I had a very interesting case where I was doing an open sky blepharoplasty, and I just injected less than a cc, like 0.2 cc of local anesthesia to infiltrate the fat pad because patient was having little pressure sensation. And immediately patient got up and had the third nerve paralysis, so both eyes third nerve paralysis. I was pretty perplexed what had happened, and only one case like that was published in literature before. but he recovered after 2 days. So we have to be very, very careful about how much we are injecting, where we are injecting, and how we are dealing with these patients. In addition, of course, I had certain procedures done on my face, not to look different, but to just. I think that was, yeah, I think that was a pre-recorded thing which came in. But yeah, I just wanted to reiterate that in addition to the surgery, what is required is a good lifestyle, good thought processes. You can have accessory or auxiliary treatments done on your face, your eyes, your skin. And I always say that aging is not lost youth, but a new stage of opportunity and growth. So keep growing, keep having those innovations in, and keep doing the good work. So thank you so much for this opportunity.
Thank you, Dr. Shubha, for an extensive talk on eyelid bags. I think this is the last talk for this session. Over to you, Femida ma'am.
Thank you, Shubhra, Kasturi. Excellent presentations. Everyone has made such great presentations. And I think that, you know, what's interesting is that it brings us back to how every one of our talks is complementary to the last talk. So I loved your results, Shubhra, great surgeries. And, you know, absolutely, it's a difficult decision whether to do fillers or whether to do surgery. I think that is actually one of these questions that I get asked every day on this patient. Should we just go with surgery or should we just do fillers? So, and sometimes the answer is both, right? Sometimes we do surgery and we need to fill more. Sometimes we do fillers and then we need to do surgery too. So I think that it's customization, as you said, Shilpa, is the best, right? We have to customize for every patient and try and have a balance. So thank you all for the excellent presentations. And I think we just want to wrap up. If there's any other questions that we need to ask, anyone on the panel? Okay, so.
Very nice presentation, and Shubhra has very nicely shown the indications for fillers and for blepharoplasty. And I just want to add one more point. If you have the lower lid bags, and if it does not cross the mid-pupillary line laterally, so that can be also one way of determining whether you just want to finish with filler or you want to do a blepharoplasty. If the lateral bags are not very prominent, many times we do the filler. Advantage of doing a filler is that it pushes the orbital septum upwards. So this also conceals the fat. So it not only takes care of the teardrop, but also it leads to some amount of fat concealing. So that is what I want to add. And I joined a bit late, so I missed many of the lectures, but congratulations, all of you. And Femida, it's so nice to meet you virtually after such a long time, and hope that we catch up soon physically.
Yeah, it's so nice to see everyone. I wish that we were all in person, to be honest, but this is a lovely way that we can connect. And thank you to ENTOD for supporting this meeting and supporting women ophthalmologists worldwide and women ophthalmologists of India. So I just wanted to wrap up and thank you all for your great presentations and thank our industry sponsor.
Bye-bye.
So wishing you a wonderful International Women's Day and see you soon.
Bye. Thank you.
Bye-bye. Good night, everyone.